You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center, and we are here today with Dr. Carrie Bedient from Fertility Center of Las Vegas and Dr. Abby Eblen from Nashville Fertility Center for another episode of Fertility Docs Uncensored. Hey, everybody. How are y'all doing?
Hey, guys. How's it going?
Good.
So this weekend is much calmer and much quieter and much less anxiety ridden than last weekend, for which I am extraordinarily grateful. If we had ended up recording last weekend, I would have been a total basket case.
Why is that, Carrie?
Oh, tell us, Carrie, what happened?
So when you guys were out here, when we did our recording session, however many months ago now, I mean, it's 2020, so 5 months is approximately 85 years ago. But when you were out here, you didn't get a chance to come out to my house, but I live kind of on the edge of town. And so my backyard goes right up to the elementary school that my kids go to, and this big park area, and there's mountains, there's like one,
like a big mountain behind y'all.
I mean, there's like a layer of subdivision and houses, but we are very much on the edge of town. So, okay, fine, whatever. There's jackrabbits and there's other, occasionally small coyotes, whatever. So I get up and I'm puttering around the house and I let the dog out and whatever. And I looked at my phone dings and I looked down at my text message, and it's one of my girlfriends who has sent me a picture of the elementary school behind my house with virtually the exact same view that I see from my house of a mountain lion sitting on top of the stairs, just hanging out, having a great time. It was taken 6 o'clock in the morning or so.
Oh my.
For the subsequent 8 hours, count them, 8 hours, my neighbors and I are all sitting out in various spots in our backyards and looking from our upper, second story out of the bedrooms, watching this mountain lion.
It just was hanging out?
It was just hanging out. It went for a run in the park. We have some really amazing footage.
Was it appropriately socially distancing itself?
It was, mostly because everyone else was
socially distancing
out. Yes. I mean, we have pictures of it in the neighborhood. It went for a swim in somebody's pool.
So can't you just call like the wildlife people
animal control
or animal control or?
Yeah. They were called at 6, 7 o'clock in the morning. They didn't catch that thing until 2 p.m.
Oh my gosh.
Wow.
Yeah. And they tranquilized it.
What exactly does a mountain lion look like, and how big is it?
I know we're uncensored here, but I don't know how far I can push this, because the words that were running through my mouth last Saturday, it's big. I mean, it is like...
we've had bobcats in our, I live
Bobcats are kind of small, aren't they?
Yeah, we've had bobcats in our neighborhood and stuff like that, but we've never had a mountain lion.
Yeah,
That's
Just the term lion sounds really scary to me. A lion in your yard.
I mean, it went up on the fence in between two houses. There's pictures of it just lounging in the shade. One neighbor took a picture of it. He had found it, he was up drinking his coffee, and he looks over and he happens to have a wrought iron fence between him and the walkway that goes up to the park. And the lion's just sitting there looking into his backyard.
Wow.
You just wake up at 8, look out at 8 a.m. having your coffee, and hey, there's mountain lion. I baked 4 sets of cookies because I was so freaked out.
And what did your family do? Were they freaked out too?
They ate the cookies.
They ate the cookies, yes. My husband was pretty calm. My kids they liked watching the videos. All the other mothers that I know who live in the neighborhood were equally as freaked out, because nobody wanted our kids and or small dogs to turn into Scooby snacks for this mountain lion. And It was down there for 8 hours. Like, I didn't hear about any kitty cats becoming
I think I'd buy a pound of ground beef and put it over at the steps of the elementary school since it was the weekend and there were no kids there. Keep it over by the elementary school away from your house.
Yeah. I mean, can you imagine if it had been during the school year?
Oh, gosh.
Oh, yeah.
Yeah. So
That's crazy.
it was big news. And they took, there were helicopters flying overhead as they were trying to track it down. It went for a walk.
You literally had a fugitive.
Yeah. Yeah. I mean, it was big news in our little suburb.
So the bigger question is, does the mountain lion have a wife and babies and relatives that live up in the mountains by the elementary school in your house?
Carrie hadn't even thought of it by the look of her face. Right
sorry,
now.
I didn't mean to bring that up. But with deer, where there's one, there's 5 other ones. So sorry, I didn't mean to bring that up.
Oh my God.
Carrie was literally speechless here.
Actually, yeah, I thought we had a delay in our video because her mouth was just open and she stopped, but it wasn't a delay after all.
Oh my God. What if there's more of them?
I'm sorry, Carrie. I didn't mean to freak you out.
Can you imagine? I mean, this lion was really pretty chill. I mean, he had himself a nice little day in Las Vegas, in the park, in the pools, running around, taking a nice jog, exploring, going real estate hunting.
Sounds like a good day to me. Yeah.
What if it has kids and a family?
So on the family note, I'm going to take this to our podcast question submission. And we have a question that has to do with family history. So our question this week is, if my mother had endometriosis, what are the chances that I could also have endometriosis? Can you test for it besides surgery?
So the number I remember is about 5 to 10% chance. If somebody in your family has it, you may have it too. Unfortunately, there's really no good way that we can test for it outside of surgery. I tell patients it's kind of like looking at a mole on your skin. You can't really see that mole unless you look on the inside. And so early endometriosis sometimes looks like little blebs or little moles. And so we have to actually do laparoscopy to be able to see and diagnose the endometriosis.
The one giveaway that sometimes you can find out early is if you've got a big endometrioma, which is affectionately known as a chocolate cyst, because as we've talked about before, gynecologists ruin food by calling disgusting pathology after delicious things. But a chocolate cyst is a big ovarian cyst that's filled with old blood. And when you go in surgically and remove it and the fluid starts spilling out, it looks remarkably like Hershey's syrup, which is how it got its name. But that is something that does have a very characteristic appearance on an ultrasound, but those certainly don't appear in every single case of endometriosis. And so when you do see them, sometimes they're big enough and clear enough that you can say, yeah, this is likely endo. But in the earlier stage 1 and 2 type cases, you don't see those. And so you don't necessarily get that tip off. And they're certainly not in every stage 3 and stage 4 case either.
So one thing I always kind of talk, when I talk to my patients about endometriosis, that I try to help them keep in mind is that, back in the day that essentially you walked in a fertility doctor's office and you immediately got your ticket to the operating room to have a surgery to look for endometriosis. Having surgery and that diagnosis for endometriosis could have some beneficial effects. Okay. So if we treated the endometriosis, you would have increased chances of pregnancy thereafter. Also, it gave you an idea of whether you had kind of a milder form of endometriosis versus a more major form. Now, when I started practicing, I think that's kind of when that was falling a little bit out of favor. And what I would end up doing is I would have these people who would be like, yes, I want to have surgery. And then we would do surgery, but it wouldn't change the path that they would want to go in their fertility treatment. So if I came out and said, you have, very severe endometriosis, I really don't think you're going to get pregnant with anything short of IVF, they would still be like, yeah, but I really want to try 2 or 3 cycles of something less. And it got to the point where it really didn't seem quite as worthwhile. You're gaining a few points of chances of pregnancy per month after having that surgery, but unless somebody is actually going to use it as a major decision-making factor, I haven't found it being super useful unless we're trying to treat for pain or somebody has a big mass or something like that.
Yeah, and that's what I was going to add in too. When I started out, we did do laparoscopy a bunch as part of the initial workup. And the thing about that is it's a surgery. I mean, it is laparoscopy. Typically, most people do great and go home the same day, but it's still a surgery and you've got the risk of surgery and you've got to counterbalance that with the benefits. And I agree with Susan. I think if somebody has a really big endometrioma, and particularly if they have pain, at least in my experience, if the endometrioma is removed and you really remove the sac around the endometrioma, those patients tend to feel a lot better. But you have to balance that with the fact that you're probably going to do some damage to normal ovarian tissue in order to get to that mass. So it's not quite as clear cut as maybe it seems in terms of what to do about that.
And always remember, one of the best treatments for endometriosis is getting pregnant.
That's true. That's true.
I have a patient coming up this Friday who we're going to transfer, and it's her second transfer. And her first one, she said, was the best treatment for her endometriosis she has ever had. She was previously just completely flattened, totally debilitated by it. And then she got pregnant and a ton of it regressed and her pregnancy was great. And so she's like, yeah, sign me up. Let's do this again. So,
yeah, I had
awesome.
Sort of a similar story that I found out about just recently. A patient that was really essentially an emergency surgery on a Friday, had a really big endometrioma, about 6 centimeters, had to call in a surgeon to help me kind of do some of the dissection because it was so big. She ended up getting pregnant with IVF. And then about 6 months after she had her baby, she got pregnant on her own.
Aw, that's awesome. Very good.
Pretty cool
Very
story.
good. So today we are going to talk about all of those crazy terms that we as fertility doctors toss around when we're talking about IVF. I think half of the battle of helping people understand IVF is just breaking down the dictionary and what are all these weird words or acronyms that we're throwing at people in a very short amount of time in a part of their life that nobody ever talks about.
So first, let's start with the who's who in the office. And so you walk in the front door, you've got your desk lady or man, could be anybody. And you've got your phlebotomist who draws your blood. And you've got your ultrasonographer.
And you'll get to know your phlebotomist really well, by the way, unfortunately, if you do IVF.
And your sonographer.
And your sonographer. Yeah, and they tend to know more about the random details of your life than anyone else, because I find out when I'm doing transfers or retrievals or whatever, the ultrasonographer who's in there with me will go, oh yeah, did you know that she was going to do X, Y, and Z this past weekend and she was going to go, skydiving and do skywriting over the baseball game for, a proposal for somebody. I'm like, how do you know these things? So they find out all sorts of bits and pieces about your life as you see them all the time. Back once you start getting into the lab, you have embryologists and you have andrologists.
And who are those people, Carrie?
And they are very similar yet different people. They're lab people. And the andrologists are primarily working with the sperm, whereas the embryologists are working with both eggs and sperm and the embryos that then result from that. So when you walk into an IVF office and you're talking about eggs versus sperm versus embryos, sometimes patients don't necessarily realize, most people know the difference between sperm and everything else, but they'll use eggs and embryos interchangeably. And it's the embryologists who are working with those materials. And eggs and embryos are very different from one another. And so the embryologists are, very highly trained to really shepherd the egg through meeting up with the sperm, going out on a date, hanging out together, deciding that they are not only going to go out on a date, but maybe get some action going afterwards, move in together, live together for at least 5 days, and then go from there.
On a sweeter note, Carrie, I think of them as your child's earliest babysitter. They babysit your embryos. So
yes. They're not just the dating service and dating planners. They are the earliest babysitters. Maybe we should start putting that on their scrubs.
Yeah, there you go.
High-tech babysitters.
That's right.
And then the other people, of course, you're going to have your coordinators, your case managers, and your nurses. Now, in different offices, those are sometimes the same, sometimes different people. And they're the ones who are helping shepherd you through with ordering your medications, telling you when to come back the next time, telling you what your next step is, your next dose is, all of those types of things. And then, of course, you've got the urologist, if one is needed. And urologists, in the context of what we do, are primarily working with helping us get sperm out in the event that masturbation and kind of normal production of sperm is not easily accessible.
If there's a blockage there, in other words.
Exactly. If there's a blockage, or if there's very, very tiny numbers and we think that we either are required to or will get much better results by having your urologist go in surgically and get sperm out for us to use. And then you've got your reproductive endocrinologist and a fertility specialist, or REI is the shorthand, which is what Susan and Abby and I all are board certified, trained, all of that nonsense. And it means that we've gone through a ton of extra schooling for, and we've all gone through training in OB/GYN to deliver babies and gynecology and all of that, and then fell down the rabbit hole of loving fertility and did extra training in that. And so we've gotten the broad general training and then focused more on infertility. And we're the ones who are driving the train, so to speak, of, okay, this is how the treatment's going to work, what we're going to do in both communicating with you as well as a lot of the science and technology behind it.
So kind of once you get started in IVF, one of the terms that was mentioned earlier is we throw around the term gonadotropins. And basically those are hormones that are secreted by the brain. They go down normally and stimulate your one egg to develop. And so normally women develop one egg on one side each month, and it typically alternates from side to side each month. But what the goal with IVF is we're trying to stimulate a whole bunch of eggs at one time. And so in order to do that, we kind of give you an extra punch of what Mother Nature gave you at the beginning. And so we give you a really high dose of those hormones, those gonadotropins, specifically usually a hormone called follicle stimulating hormone, or FSH. And so that's the hormone that we have to kind of tinker with and regulate for each individual person to figure out kind of what dose you need. And then ultimately, after a period of, somewhere between 8 to 12 days, somewhere in that range, your eggs, and hopefully there's a whole group of them that come along together at the same rate, get mature. And then ultimately, we use a trigger shot. And so many people are familiar with the trigger shot, even when you don't do IVF, because we trigger eggs even in cycles where we're going to do other procedures. But for IVF, it's really critical that you get the trigger shot at a specific time, because if we don't get the eggs in time, they may release into your body without us being able to go in and take them out. So the trigger shot is basically a hormone that sort of mimics the normal hormone that would cause ovulation. You get that, and we time it pretty specifically in terms of when we're going to then do the egg retrieval. And then basically you would come in for the egg retrieval on that morning after you get the Ovidrel shot, and then we would put you to sleep. And Susan, you want to take it from here?
Yeah. So just to add on a few things about the trigger and some other things that are happening during the stimulation. So there are actually a number of different ways or medicines that can be used as your, quote, trigger shot. And some of those things are going to depend on your physician preference, how your ovaries look, how high your estrogen level is. And so generally the two categories of those trigger shots are going to be some sort of HCG hormone, which is pregnancy hormone, or what we call our lupron trigger, which makes your brain shoot off a hormone called LH. Well, the interesting thing is LH and pregnancy hormone in the body look almost exactly like each other. And so that's why they're used interchangeably, but they can have different effects in helping decrease risk of things like ovarian hyperstimulation syndrome or OHSS. Some other things that we also use during a IVF stimulation are medications to keep you from ovulating. So generally the way the body works is once your estrogen levels get to a certain level, your brain goes, ooh, I need to ovulate and shoot off some of that LH hormone to make ovulation happen. Well, in IVF, we don't want ovulation to happen because we want to be able to get all those eggs. So we add
we don't want your ovaries shooting off without our permission.
Yeah,
exactly.
No shoot your shot early.
We're a little bit of control freaks, and that's okay. So we can give you some medicine, typically something like Ganirelix or Cetrotide. Sometimes we use the Lupron that we talked about earlier in a different fashion that can also keep you from ovulating. But those are some important components to keep everything in your ovary until we are set for it all to kind of culminate at the time of the retrieval.
So once we are to the point of retrieval, then patient comes in and we put her to sleep with anesthesia and we go in with the ultrasound with a special needle on the end and we pull out all those eggs. Now, it's important to emphasize the difference between eggs and embryos because this is something when patients come in and they will occasionally refer to eggs and embryos interchangeably. And early on, when we're just in the diagnostic phase of treatment and testing, that's okay because we're still just talking in vague terms and more abstractly. But when we actually get into the cycle, those things are very, very different. And they mean very different things for your future childbearing. An egg is just what contains half of the chromosomes, and it's what the woman gives in her contribution to making a baby. And that's compared to an embryo. So an egg is just one cell, and an embryo is the combination of both an egg and sperm. So sperm would be the other half of chromosomes coming from the male contributor. And it's the combination of those two together where not only have they joined, but their chromosomes have become functional, and all the machinery inside of that now embryo, or a very early embryo, is called a zygote, right after it's just started to form. All that machinery has kicked into gear, and it goes from being one cell to 2 cells to 4 cells to 8 cells, and just keeps doubling and doubling, doubling until you get to an embryo.
Hey, Carrie, one point, sorry to interrupt, I wanted to make, and this goes a little bit into genetics, but I think it's kind of really important for women to understand. We talk about age and its impact on cell division and fertility. And one of the really key things that has to happen is when a woman's egg is stored in her body, as many of you know, she has it stored for her whole entire life. In other words, she's born with all the eggs that she'll ever get. And those eggs just sit there in limbo. And then all of a sudden, when you get that trigger shot and you ovulate, all of a sudden after, whatever your age is, 38, 39 years, whatever, the egg has to wake up. And all of a sudden, it has to kick out half of its chromosomes in order for the sperm to join. And unfortunately, that's the problem. I always tell my patients that's kind of the glitch in our female system. A lot of times that just doesn't work so great, that the cell doesn't divide very well. And so that's why when embryos sometimes have an abnormal number of chromosomes, we usually blame the egg because unfortunately that's usually where it comes from. And so I think it's just important for patients, for you guys to understand that that's kind of one of the things about our female system that just doesn't seem fair.
So I don't consider it to be a glitch. I always just tell my patients that the chromosomes that are in pairs at that point, when someone's 40 years old, for example, those chromosomes are best girlfriends and they get the the instructions to separate and go their own different ways, and they're best girlfriends. And so they, of course, say, screw you to that set of explanations, and then they don't do it. And so I think that it's not a glitch. I think it's just good friendship.
Oh, okay.
It may have deleterious results.
One additional thing to keep in mind for our patients who are listening out there is, although we were talking about how age has that effect, realize that the humans are very, very inefficient at making babies at baseline. Okay. There are lots of critters out there on Earth that are much better at this than we are. And that when we're talking about embryos potentially having chromosomal abnormalities, even when you're young, even women who are in their 20s, about half of the embryos they create are chromosomally abnormal. So at baseline, we're hitting a 50-50 game on whether we're making chromosomally normal embryos. Now, most of and I don't mean for everybody to freak out being like, oh no, I'm going to have a chromosomally abnormal baby. Our bodies are very good filtering mechanisms. And most of those abnormal embryos are never going to implant. And most of the ones that do implant end up resulting in miscarriage. So that's why very few babies are actually percentage-wise born with chromosomal abnormalities. Now, when women start to get into their 40s and especially mid-40s, it's estimated that potentially about 90 to 95% of their embryos at that point are chromosomally abnormal. And that's why it's so challenging when we get into kind of the 40 decade.
So let's go back to the eggs for a minute. So once we get the eggs out, they go to the laboratory, and then Abby, tell us what the lab is looking for and how they're classifying those eggs and why not all eggs are created equal.
So kind of the first thing the lab does is they look for the polar body. And the polar body is kind of like the little capsule that kicks out those chromosomes that aren't needed by the egg. And so they also look to make sure that the egg is mature. So sometimes if the eggs are not mature, they'll label them as having a germinal vesicle, and ultimately those are eggs that are too immature to fertilize. And so they'll look first to see which ones can be fertilized. The ones that can't be fertilized are considered as immature, and essentially they're just kind of eggs that are not usable. And then later that same day, they'll actually take the sperm with one needle. They'll take one single sperm, penetrate the egg to bring about fertilization. And so essentially from the point they do the ICSI procedure, again, that stands for intracytoplasmic sperm injection. From the moment they do that procedure, the egg and the sperm start to do their thing. And there's many probably mechanisms and things that have to happen in that time period that we really don't have testing for. It's sort of out of our hands at that point. But the next morning, roughly about 24 hours after the eggs have been taken out of the patient's body, they can check and see how many have actually fertilized at that point. So they'll look for something called a male and female pronuclei. And at that stage, the embryo is one cell. It only has one single cell. And over the course of about 5 days, that one single cell goes from one cell to about 140 to 150 cells as it grows and divides. Ultimately, we can also check it at different times in its development. And we tend to do that less so now than we did before. We think it's better to leave our little embryos in the lab and keep them in the incubator and not bring them out and check them as much. But if we were to check them around the 3rd day of development, at that point, we should ultimately see about 6 to 8 cells. And at that stage, hopefully they'll continue to grow and divide. But from day 3 to about day 5, they really get jump-started and grow really quickly. And on day 5, that's when we actually label them as a blastocyst. And so that means that there's a cavity, a cystocele cavity. There's an area that's called the inner cell mass in the embryo, and there's an area called the trophoblastic tissue. And those are very, very early developments in the baby's life, in the embryo's life. And so the inner cell mass will actually become the baby. The trophoblastic tissue will become the placenta, and the blastocele cavity will actually become the early amniotic sac.
So when we're taking a look at these embryos, like Abby mentioned, sometimes we always look at them on day 1, and we always look at them on day 5, and that's based on the day post-retrieval. Nowadays, we're looking at day 3 less, but remember, embryos go through a major metabolic stress on day 2 and day 4. Okay. And so as embryos are developing, it is normal for not all of them to survive to that blastocyst stage. Okay. Now, embryos that do make it to that blastocyst stage, they're pretty nifty. They are very resilient little suckers. And at this point, the embryologist typically grade them. Okay. Now, there are lots of different grading systems, and we're not going to get lost in the minutia of that today, okay? But realize that there are going to be some that are good, and those can have different grades, and there are going to be some that are so poor quality that we know that they are not going to result in a baby. Okay, and there's good data to support that. And so at that point, the decision is made is, are you going to have a fresh embryo transfer or a frozen embryo transfer? And kind of the big differences of those are a fresh embryo transfer. It implies that the embryo has never been cryopreserved. So you're coming off your egg retrieval, they've put you on some progesterone, and that little embryo is going to get put in, around day 5 or day 6 after your egg retrieval. Now, what's becoming more and more common for a number of reasons is for the embryos to be cryopreserved and then coming back in a subsequent cycle to put that embryo in. Now, some big reasons why that's come about in the past 5-10 years is, number one, more people are doing chromosome testing, or what we call PGT, pre-implantation genetic testing, on the embryos, mainly to make sure we have the right number of chromosomes. We call it aneuploidy, but making sure there's the right complement that's going to make a healthy baby. The other reason behind that is that we have found in certain groups of people that all those hormones that are going crazy during your IVF cycle actually create not such a great environment for implantation. So if we can let things settle down and calm down and really create that perfect little home for an embryo, we're getting better success rates.
So some of the alphabet soup that people get confused by is looking at how the embryo testing is named when we're looking at genetic testing. And so that is a whole extra episode all by itself. But the current terminology is PGT, pre-implantation genetic testing. And then there's a hyphen with a letter after it. And the most common is A, which stands for aneuploidy, which, as Susan was talking about, is really addressing whether there is an extra chromosome present or a missing chromosome present. And the embryos are very sensitive to that extra or missing genetic material. And even if it's just one chromosome, that is enough to throw the development off. And so we don't use those. And so we'll talk in more detail in a future episode about all of those details and what the different types of genetic testing are. But that's an important one to know. When we are talking about doing genetic testing with PGTA, that is done typically on blastocysts, so those day 5 embryos, rather than cleavage stage embryos. Cleavage stage embryos are embryos that are typically on day 3 or so of growth. By day 3, you really only have about an 8-cell embryo. And so if you can imagine taking out a couple of cells from an 8-cell embryo, that's a much bigger proportion compared to taking out 4 or 5 cells from a blastocyst that has at least, let's say, 150 to 300 cells. That's a much smaller fraction and something that's much easier for the embryo to tolerate. And so that's part of the reason why blastocysts tend to be where the majority of clinics grow their embryos to. All right. So we've talked about fresh versus frozen. We've talked about all of the blastocyst cleavage lingo, eggs versus embryos, GVs versus M2s. Do we miss anything, ladies?
think we got it all.
If not, we will have another episode.
Say, give it a week, and I'm sure the terminology on something will change. I feel like the genetics testing terminology changes about every 6 months or so. It's been stable for what, a year now?
Yeah,
2?
they'll probably change again though soon.
I sometimes for our audience, you maybe read something that talks about PGS. PGS is just the old term for PGT with the whatever letter after it. I remember our first national meeting where there was this big change of PGS to PGT. I thought like every other word people said was PGT. I think they were just trying to say it as many times as possible so that they could remember what they were saying.
Well, and just to throw one last term, this is a vintage term for IVF, if I can use that terminology now. This is something that you may look up and find it on the internet. And occasionally I actually get a question about this, even to this day, because things never die on the internet. So we don't do gift anymore. That's called,
oh, no.
That stands for gamete intrafallopian transfer. And that's where basically back in the day, before embryologists could really grow embryos very well in the lab, they would actually laparoscopically remove eggs from a woman and basically in that same procedure go back in and mix her husband's sperm and the egg together and put them in the fallopian tubes. We don't do that anymore. That was a long time ago.
Good
so that's
stuff.
the alphabet soup that we don't have to worry about anymore.
Yeah, always changing, always growing, and that's what makes what we do so exciting. So thank you, everybody, for listening to another episode of Fertility Docs Uncensored. To our audience, thank you for listening. Please turn next week for more exciting insights into your fertility journey. Also, be sure to subscribe and leave us reviews in iTunes. Would love to hear from you.
You could also visit us at fertilitydocsuncensored.com to schedule an appointment with any of us or to submit specific questions you have about infertility. All the questions will be answered on the podcast anonymously for our Ask the Docs segment. So don't hold back. The more embarrassing, the better.
All right. We'll see you guys soon. Thank you.
Bye.
Bye-bye.